I'll take a moment to introduce myself. I'm Dr. Tom Milam. I'll be your host and moderator for this webinar, for this panel discussion. I want to give a special shout out to, I mentioned her name, Ellison Glass. She and her team and our marketing division are just incredible. They've worked really hard to pull all this together. Panelists and everything. I want to thank her and for all the work that they've been putting this together. It takes a lot of work. I want to thank her and our panelists for joining. I'll introduce them in just a second. But again, Tom Milam, I'm a psychiatrist, Chief Medical Officer at IRIS, President of our medical group. IRIS is a behavioral health medical group, nearly 450 US-based providers. They're psychiatrists, psychiatric nurse practitioners, and therapists. We are in 44 states across the US, and we focus exclusively on providing high-quality behavioral health care and substance use disorder treatment 100% virtually. So all of our providers are working remotely from home or home offices. And I am joined today by three really talented and gifted panelists whose organizations we've partnered with for quite some time. First, Sue German is CEO at Pine Behavioral Health in Michigan. We have Melissa Espinoza, CCBHC Program Director at HealthRight 360 in California. And then Sean Ramola, who's the medical team manager at Deschutes County Mental Health in Oregon. I'm going to give each of you a chance to introduce yourselves a little bit more and do presentations in just a second. I want to give an overview of the CCBHC model just for a few minutes, and then I'm going to have each of the panelists introduce themselves individually and then present their PowerPoints. We'll go through each three of those. Then we've got a series of questions I'm going to go through and ask our panelists and have you all, the three of you, just kind of speak up and answer these questions. They may replicate material you presented in your PowerPoints, but I think we've tried to have some good questions that are kind of on the minds of a lot of people that are thinking about CCBHCs, what they are, maybe becoming one, and what it takes to do one, and what that journey's been like for each of you all. So, and then as I said at the end, we're going to go into audience member questions. So just real quickly, CCBHC stands for Certified Community Behavioral Health Clinics. Certified Community Behavioral Health Clinics. These are specially designated clinics that offer a very comprehensive range of services to treat mental health and substance use disorders. They're integrated into existing community clinics of all different kinds, and you have to apply to become one. It's not an easy thing, so we're going to hear about that journey today. And organizations have to be granted this designation. There's a lot of work to do up front and ongoing work. It is not a small effort at all, as we will hear. CCBHCs offer a different model in some ways. It is an evidence-based treatment model. They focus on specific target populations and try to address metrics in evidence-based care, things around access to care, quality of the services delivered, the diversity of the services and sites and patient populations where they're there. And they can be tailored over time to meet the various needs of each patient population in the community where they serve. So it's not a one-size-fits-all model. So that's pretty cool. First CCBHCs were launched back in 2017. There were about 67 initial ones in 8 states, and they were the kind of the initial pilots of that. 2017, that's 6 years ago. It was not that long ago. Now there are over 500 of them in 46 US states and territories. So that is incredible growth. And these are really high quality, reputable organizations doing this work. In March of 24, or just March 24th of this year, the US Department of Health and Human Services announced an additional $120 million in funding to support new CCBHCs and expand existing ones, which is really cool. And I want to conclude by reading a comment from Dr. Miriam Delphin-Rittman, who is Assistant Secretary of Mental Health and Substance Use at the Health and Human Services and leader of SAMHSA. She said just a few months ago, data show in the first 6 months of receiving care, CCBHCs decrease homelessness, decrease the amount of time spent in correctional facilities, decrease the time spent in emergency rooms for behavioral health issues, decrease inpatient hospitalizations for mental health treatment, and decrease the use of illegal substances. So that's just really cool. I mean, that's just amazing. Are not those some of our main goals? I mean, those are goals of IRIS with all of our partners all over the country, inpatient, outpatient, EDs, treatment centers. Those are some of the goals, just keeping people well in their communities, keeping them well physically, mentally, helping them with addiction issues. It's tough work, but it's incredibly meaningful work, and I'm still grateful every day to be a psychiatrist and work with an amazing team of people at IRIS Telehealth and around the country. Let's go ahead and turn to our first panelist, Sue German. Sue, tell us a little bit about yourself and your organization, and then feel free to jump right into your PowerPoint that Ellison will queue up for you.
All right. Well, hello, everyone. And first, I wanted to say thank you to IRIS for giving me this opportunity to talk about our journey. Thank you very much. I am the CEO of Pines Behavioral Health, and we are a public mental health, public community mental health system in Michigan. So Michigan is has a lot of CCBHCs across our state. So just getting into my PowerPoint, we actually started hearing about the CCBHC program back in 2014. Our state applied for the planning grant and then eventually applied for the demonstration, which it didn't get right away. But as I was hearing more and more about the CCBHC, I was, to be quite honest, I wasn't an early adopter of it. I didn't know enough about it to really jump in both feet. It sounded very complicated, quite honestly, when I first heard about it. The way that the Michigan mental health system is set up is that it's the public community mental health system is a carve out of the Medicaid health plans, which are HMOs basically. And so our specialty was serving those with the most serious mental illness and developmental disabilities, and kids with serious emotional disturbances, and then substance use disorders. Whereas the Medicaid health plans were responsible for those with the mild, moderate symptoms, and then the VA was responsible for the VA. So in learning about the CCBHC, what concerned me the most was, number one, here's a new project. Do we have time to take on something new, given everything else? And number two, how in the world would we serve all these additional populations that would be required to serve regardless of location? And so it was just a very different world. So I chose to sit back and kind of learn from others. And when the CCBHC expansion grants came out, that's when a lot of the other CMHs went forth and applied for some of those grants. So I was able to kind of take a look and learn from them, kind of, what are the challenges that they're facing? What are some of the good points that are occurring as a result? And then COVID happened. And that really opened my eyes in terms of the gaps that people were noticing. Our legislation for a long time had been wanting to revamp the mental health in some kind of way in order to meet the gaps in services and increase access. And it became so very apparent to me during the pandemic crisis that we've got to do better. We've got to do better. We can do better. And it was also a very opportune time because there were so many opportunities to apply for the CCBHC. It used to be the expansion grant would come out every 2 years, and all of a sudden it was coming out every year. And there were more and more CCBHCs that could be awarded. So it's like, if we're going to do this, we need to do it now. And so without having ever applied for a federal grant, we went ahead, had no clue what we were doing. And when we received it, I wasn't sure if I should be afraid or if I should be happy. It was just a total mix of emotions for sure. Next slide, please. But we did go ahead, and I'm glad that we did. In doing so, some of the challenges and strategies, the certification itself wasn't difficult for us. Michigan's requirements of the community mental health agencies are very similar to the certifications that were required of a CCBHC. So that was fairly easy for us. Figuring out what to do with the new folks coming in, the mild moderate population coming in, how to navigate the VA system, those were probably the biggest challenges for us. Not to mention the national staffing shortage. That was huge for us. When we had applied for our grant, we had applied for several different master level positions to help us out. We weren't able to, find hardly any, maybe two at that time. So we had to really look at, how can we meet the goals that we've set forth in this grant with maybe different level of staff. So we did hire a lot of peer support specialists and a lot of bachelor level folks that could serve the needs of, the person served instead of maybe a master level clinician. We also, our access or our demand actually increased by 36%. So obviously every, service that we were providing, had greater need. And one of those was psychiatric. And that's where Iris really helped us out, is we were able to connect with Iris right away and on a virtual psychiatrist for us, which was invaluable. Really, really helped out. And then we took, we all were kind of thrown in the midst of having to learn how to do services by telehealth anyway. So that definitely helped, meet the demand that was there. And another challenge, I think, was assimilating the staff that we had with the new grant staff. Because I don't feel we did enough education in terms of CCBHC is not a program in and of itself. CCBHC is a model of care, and that these folks were to help the agency as a whole, not a standalone program that was going to go away after 2 years. So there was some tension between our staff. During that time, we probably doubled our staff. So there was like new people walking down the hall all the time, and that was somewhat difficult for our staff that we had already in place to kind of assimilate to. Administratively, there was a lot of administrative additional work. We were able to get through that through the grant. The grant helped us hire some additional administrative people. The NOMs, of course, you got to kind of get used to the NOMs and the whole IPP reporting system and that kind of thing. And a challenge that we didn't think was going to be a challenge was when you go the grant way, is that you're serving those who are non-Medicaid. And during the COVID early years, everyone was on Medicaid. So what we thought we would be able to do with the grant, we really had to rethink, how do we do this for individuals without Medicaid? And at the same time, be able to sustain this once people start dropping off of the Medicaid rolls and maybe get a job and have commercial insurance, that kind of thing. So it was those sustainability strategies that we had to really work through. Next slide, please. What we did, one of the benefits, so I'm really interested personally in program development. That's kind of my thing. And that was something we could really, really do through a CCBHC, is you can be unique. You can finally meet those, the things that the community wants that isn't necessarily Medicaid allowable. So you can really be creative, and that was really fun. So we created a health and wellness program where you didn't have to come in and have an assessment and a treatment plan before you could have the service. You could come in and learn how physical health, we had a cardio group, you could learn how physical health impacted mental health. The CCBHC expansion grant helped us with our 24/7 crisis team. We went from scheduling intakes to same-day access, come on in, and we really made sure that we had enough staff to be able to meet that need. And that helped us in terms of being able to meet the measures related to how quickly you needed to see someone. We ended up hiring a veterans navigator to help us figure out veteran services, in addition to helping veterans and other members of military figure out how to navigate through the system. And then all the coordination of care agreements that you need to have as a CCBHC, I think was really beneficial for us because it really helped us learn about new partners and find out more about their services and what they can do. And they learned more about our services, and it just really developed a better community collaboration. So, and now that's another benefit, is just our reputation really increased as a result of being a CCBHC. And it was very clear because in 2020, our state did become a demonstration state. And so it was very clear that that was the direction of our state. So having been a CCBHC under the expansion grant gave us recognition from the state too that, hey, we could be one of the considering partners for the demonstration. Next slide, please. And that is one of our priorities for 2023. We've just been added to the state's demonstration project, which is, we're very thankful for that because we received the expansion grant in 2021, and so that ended at the end of August. And so beginning in October, we will start the demonstration. So it was very easy. We had plans in place to sustain it, but it's now reality that all the things that we started will be able to continue and expand. In addition to that, we also applied for the CCBHC IA grant. So that will give us that additional flexibility, and we're awaiting word on that. But regardless of that, what we're prioritizing for 2023 is zero suicide. The CCBHC grant allowed us the opportunity to get people trained in being zero suicide trainers. So our intention is to really expand that across the community this year and over the next few years. Really start to engage more with individuals that need substance use treatment but aren't engaged in such treatment. Expanding crisis stabilization services. And now that, even the CCBHC expansion and especially the demonstration has the formal quality measures, we're having to pay a lot of attention to, getting our systems in place to meet that. And then just continue long-term planning. The demonstration is for 4 years, but we don't intend to stop doing what we're doing in 4 years. So what does that long-term planning look like in continuing to strategize in that area? So in all, it's just been a fantastic journey for us, a growth period for sure, and lots of learning, but definitely worth it.
Yeah, no, thanks so much. It's really fascinating. I didn't realize that the ability to involve veterans. I mean, it makes sense, and that's the flexibility with CCBHC, and because working directly with veterans clinics and their healthcare system and EMR, just really challenging. I've done that over the years. So allowing veterans to come into clinics that can engage with providers and clinicians in this model is really fantastic. So thank you for that. And yeah, we're all familiar with the NOMS, the National Outcomes Measurement System, and trying to get evidence-based care and unified on that. So that's part of it. They're one of those hoops you got to jump through. And but thank you very much, and I appreciate that. And Melissa, I'm going to turn it over to you. You could please just introduce yourself and tell them about your organization and jump right into your PowerPoint.
My name is Melissa Espinosa. I am the CCBHC Program Director for Health Right 360. Our CCBHC is actually operated out of our Pomona, California site. It is the only site within the agency where we do employ the CCBHC model of care. Prototypes is actually a program of Health Right 360. They have a family of programs that operate in the state of California, from San Francisco down to San Diego. And so we're kind of, Pomona is kind of in the southern part of California. And so we have Prototypes in general has been a provider of behavioral health services in Southern California for decades. And so when we merged with Health Right 360, their organization was more focused on the physical, medical side of things, and then as well as substance use services. But in Southern California, our agency doesn't have that physical medical care component, and so this model of care was great in bringing all of that together. Next slide, please. So you're going to hear a lot of similarities to what Sue was mentioning in Pines Behavioral Health, but our CCBHC certification process began in 2020. We applied for the CCBHC expansion grant through the Notice of Funding Opportunity through SAMHSA. California is not a demonstration state, and so we are continuing to advocate for that with our legislature and with our advocacy groups we work very closely with as a movement toward becoming a demonstration state. The goal of taking on the CCBHC funding opportunity and model is to enhance our longstanding outpatient behavioral health programs in LA County and potentially to replicate this throughout other sites within the agency and organization. If you remember, in 2020, we also obtained the grant, and as soon as we did, of course, the pandemic hit, and so we also had to reshift and refocus the entire delivery of our behavioral health services to the virtual platform, and had to become very familiar with telehealth and how we were going to continue to operate not only at the level that we were prior to the pandemic, but then in addition to that, enhancing the services through the CCBHC model of care. So it was quite daunting. We were successful. There were some obstacles and bumps in the road because as we all can align with, we were not prepared for that. And so it took a big shift in not only our staffing, but in the thought and how we were providing uninterrupted services, for behavioral health care through the model. Next slide, please. So similarly to Sue in Pines Behavioral Health, one of the biggest challenges that we faced at the beginning of our CCBHC process was the staffing issues. And so we did originally hire an entire CCBHC team that was looking to employ the enhanced services. And little by little, as we worked, a lot throughout the pandemic, people started to drop off. And so it became very difficult for us to retain a separate CCBHC team. And so a lot of the, we'll call it extra work that came along with the model and the funding fell on our already established staff. And so as we all know and can acknowledge in this field, that everything feels like more. And so there was a lot of staff burnout. There was a lot of, long-term staff that had felt kind of like they didn't want to be a part of this. It was too much extra. And so staffing was definitely a struggle that we had to overcome. We are finally stabilizing. And so we are, we did learn a lot from our first round of the funding, and we were able to make adaptations to our staffing plans and our training plans as we move forward out of the pandemic and more into this new normal that we're functioning in this realm these days. So one of the things that we were really trying to do in order to obtain and retain staff, since it was such a difficulty for us, was to enhance and strengthen our benefits package, to incentivize staff to stay on board with us. Maybe they were early on in their licensure process, or they were not intending to stay long term. And so we were really trying to find ways to strengthen the pull toward our agency and toward this program in general, to help us focus long-term and how we were going to sustain the CCBHC model of care. So in 2022, we applied for the next round of funding, which was the CCBHC IA grant, which the IA stands for Improvement and Advancement. And that's where we are focusing now, on developing a sustainability plan and to, always improve and advance the services that we are able to offer to our clients. If you work in the behavioral health realm, some of the challenges around making changes to services that are available to clients is that there's not a lot of funding behind that. And that was one of the great things about the flexibility of CCBHC funding around this model, is that we were able to take the services that we've been employing for a very long time and enhance those services, and be able to offer, to evaluate and assess the needs of our clients. Those are always changing, and then being able to enhance the services to meet those needs of our community. Virtual care has not gone away. That is a part of our long-term strategy. We do know that there are clients who do prefer and benefit from in-person services, but there are also clients that really do value the flexibility in their own schedules to be able to participate in treatment through that platform as well. So currently in our CCBHC, we are offering a hybrid model of service delivery for our staff. It allows them the flexibility, and it allows the clients flexibility to be able to continue with treatment through our agency. Next slide, please. So there are a lot of benefits to becoming a CCBHC. It has allowed us the ability to assess and address the needs of our population in ways that we were not able to. One of the initial requirements for a CCBHC is that you are required to do a community needs assessment. And so instead of taking long established services and fitting clients into those boxes, we are able to really survey and obtain feedback from clients about what their individual needs are through their experiences and their feedback. So that has been really important. We just completed our second or reassessment of our community needs. Those are required to be updated every 3 years. And so we had a lot of data, both through our NOMs and through our CCBHC advisory group that takes place every quarter, where we were able to take that feedback specifically from clients and inform our community needs assessment so that we can continue to adapt and evolve our services. In addition to that, the lens of CCBHC in treating the client as a whole person rather than just in the chicken, what came first, the chicken or the egg, the substance using behaviors or the mental health symptoms and behaviors. And then we all know that behavioral health symptoms and behaviors impact physical health care, as well as physical health care needs impacting behavioral health behaviors. So there is, being a CCBHC and operating from the stance of treating the whole person rather than one ailment or one situation at a time has been very impactful for us. And then similarly to what Sue was talking about, what happens when you can't meet a CCBHC requirement internally? So we at Prototypes in Pomona do not offer primary care services. And so those collaborations with local community partners becomes very key, establishing formal partnerships, MOUs and BAAs, and being in agreement with like-minded community partners who have similar morals and values agency-wide has been very helpful in not just meeting the needs and requirements of the CCBHC model and the funding stream, but also for our clients and being able to help support them, you know, whether that's physical, you know, medical appointments, if they're dealing with chronic medical issues, or, you know, maybe dental care or optometry, things like that, that maybe have gone unaddressed for quite a while. So that's been a really good connection for us, and it has helped retain clients and also address positive outcomes for them with their behavioral health treatment that we offer in-house. Next slide, please. So before we pass it over, CCBHC, I'm very passionate about CCBHC, and another area that Health Right 360 is focusing on through CCBHC is really advocating for the model. And so in California, that's become a big movement, trying to get there. As Tom was saying, there are now over 500 CCBHCs throughout the nation, and I don't think this model is going anywhere, especially with the national attention and the national dollars that have been committed around CCBHC models of care. So this is a great opportunity. We have felt it's a great opportunity as an organization, and we look forward to what's to come in the future.
Great, thank you so much, Melissa. That was really interesting, and you know, helping all of us see that the whole person focus here. So it's not just about mental health and substance use disorder treatment. That's a piece of being a CCBHC, but it's integrated into the whole person. And those of us involved with mental health care know that you know, dental care, just general medical care, help getting prescriptions, help getting rides, transportation, family care, food, all these social determinants of health are very important to the overall wellness of people. And organizations like yours and the others here and many around the country are just doing fantastic work. So thank you for that. And I will now introduce our third panelist, Chandra Mola. Chandra, go ahead. Tell us a little bit about your organization, Deschutes County, and jump right in. I think you're still muted, Chandra, maybe.
By trade and medical. Is it on?
Yeah, sorry, it just popped in, so thank you. Sorry.
No worries. Nurse by trade and the medical team manager here at Deschutes County Behavioral Health. We have been a CCBHC now for going on 6 years. We were one of the first to receive the grant, and yeah, I'll talk a little bit more about that. Next slide, please. So as I said, we were certified in 2017. What really drove us to seek certification was we had one of our clinics at our downtown clinic, which serves our FPMI population. We had a small integrated primary care office, and it had kind of a one-stop shop, and just really saw the benefits of having that whole person care, collaboration, and improvements with overall health. So that was kind of one of the driving pieces, was to be able to expand that to our more rural locations and really offer that at all of our sites. And then the second piece was really just a plan to diversify our funding, being just dependent on our CCO long-term sustainability-wise. This was an opportunity to look at other funding sources. So that also drove us to look for or to apply for this grant. And honestly, the benefits have been just overall improved health outcomes. We've seen decreases in blood pressure. We've seen better managed A1Cs. BMI is still a tricky one, but we have seen a little bit of improvement there. So just that whole person care has just driven us to decide to adopt this model permanently, whether the feds decide to do away with the program at all. And then it really expanded our staff support this robust team approach to care that we have, that we already had on board. So being able to add more peers, more nurses, and more QMHPs, and expand our team-based care was very important to us and a great benefit. And then again, just enhancing relationships with our community partners. We relied on our FQHC to integrate into all of our campuses, primary care clinics, and provide that very easy care coordination. Next slide, please. The implementation challenges, SAMHSA grants are daunting, they're big. It certainly just being able to deal with the administrative burden that it put on every aspect of our departments. The opening it up to broader groups of people, offering it to people that had private health insurance, things like just setting up the billing department to be able to bill for all of that. And then NOMS still is a bit of a challenge for us, just managing that piece of it, and then the reporting. And then staffing challenges was the other big one. Early on in 2017, we were really able to just expand staff. Our staff was very accepting of it. We didn't have challenges as far as staffing turnover at that time. But then when COVID hit, for I think so many different reasons, we really had just a lot of turnover with our longtime staff during COVID. And then all of a sudden it was difficult to hire QMHPs and nurses. We're still struggling with nurses and NPs, and that's where Irish Telehealth has certainly been very important to us, filling in that telehealth. We didn't use psychiatry, but nurse practitioner role for us. We've always had a balance, but we have lately had to leverage that more. And it's very effective. It serves its purpose. It meets a lot of folks in our rural areas that really struggle to get into the clinic for in-person care. So that has been a very important piece of our work. And then lastly, space challenges with the expanded staff and integration of primary care clinics into our facilities, and just the property values and the place that we live. Space challenges have been a big deal for us, and an expensive project that we're continuing to expand all of our buildings to really make kind of one-stop shops for our folks. Next slide, please. Current goals and kind of our long-term plans. We're just really continuing to kind of promote this team-based holistic care with all of our community partners. We're doing a really great job with our FQHC in offering that intensive care coordination, which again just leads to better health outcomes for our clients. And hoping that we can kind of expand that through to our specialty care providers and just continue to build that intensive team-based care in our community. And then optimize our space to support better integration, thinking of things, making sure that we're coexisting on the same floor. Lots of thought is going into how we are planning our space so that we can really work to improve that care coordination. And then we're also working on efforts to support the rebasing of the PPS payments, the RAP payments. It hasn't been done for 6 years. We as a CCBHC are currently struggling to meet the minimum payment to receive that RAP payment. And we're hoping that rebasing, which there are efforts in place as of now, will help us better be able to meet that and receive that RAP payment. And then, of course, as we continue to apply for these expansion grants, we are working to upgrade our processes to implement the next round of updated requirements and make sure that we are able to sustain the model long term. And then we also have efforts at the state level. Oregon is, and certainly Deschutes County is such a supporter of the CCBHC model. that we are hoping, Oregon is hoping to become a CCBHC state of its own and sustain the model regardless of whether or not the grants continue long term. We are all working to support that effort.
Mute myself. Thank you, Chandra. That was really interesting to hear about what's going on with Oregon. I know we do a lot of work in Oregon as we do across the country, and some states just have unique ways of doing things. Some are, really buy into behavioral health and integrated care, and others it's more of a challenging, the funding in the state, Medicaid, and how it's managed in the state to cover a lot of the services. Thank you, and thank all of you for sharing this. I want to take a second to point out some themes that I hear that you all shared and talked about. One, COVID didn't do anybody any favors, but we survived. We got through it. And I mean, with CCBHCs coming out in 2017, you think not too long after that, 3 years after that, COVID really hit, and people endured it. And all of you and your organizations helped communities continue to offer access to care to patients and get the care that they needed. And that just in itself is a lot of work. And then becoming or being and expanding your CCBHC status that was incredible. So, and the staffing too is another thing. That's a real challenge. We hear that everywhere, not just the shortage of psychiatrists or mental health professionals, but just techs, staff, scheduling people, just do they want to work from home or here or what? And how you manage the space stuff like you talked about, Chandra. Is it better to have people work from home? Is it, how do you do your admin and just some of the burdens there? So, and just having the bodies to do that is a challenge. And it's getting a little better, but that's still there. Integration was another theme that I heard. Just behavioral integration into X, whatever that X is, and that includes substance use disorder integration treatment. And I think that really is the future of those integrated care models, so that patients can be seen as a whole person and not parse out things. And you get stuff in the medical field that historically we have parsed things out to specialists and all. But behavioral health is not a state, it's not a disease or a diagnosis, it's a bunch of things. And so it takes a lot more effort, staff, and time to drill down on what each client, patient is struggling with, and how we can reach out to him or her or them individually, and also populations like them throughout our communities. So, and the last one was flexibility. You've each mentioned that the flexibility afforded through being at CCBHC, that you can look at, as I said in the beginning, not a one-size-fits-all model. There's some measurement-based things and things to follow, but you're able to put things where they're needed and shift that around a little bit, see what's working, what isn't, and continue to evolve it or enhance it. And hopefully now with this new grant money coming out, that'll be enhanced even more. So I just want to thank each of you for the efforts you and your organizations are making in this CCBHC model. Just a few questions I'm going to jump into. We don't have time for all of them, and Allison will let me know if we have some from the audience. But and I'll just go each through Sue, Melissa, and Chandra. What would you say, looking back over that journey? First question, was it worth it? And secondly, what do you think is like the biggest take home that you would want to share with organizations that are looking at becoming a CCBHC? What would you want to tell them? So was it worth it? And what would you want to tell somebody that might follow suit? Sue? Yeah, I think we.
Okay, now I'm unmuted. All right.
Here we go. Great.
Okay. I think the two questions were, was it worth it, and what would people?
Yeah, what would you share with another group thinking about this?
Okay, I would say it was definitely worth it. You know, I just, you know, the flexibility, like you said, the coordination, the type of care, the whole model of the whole person integrated treatment is just, I think it's fabulous for the people that we serve and for the community. So my personal opinion is you can't go wrong. The biggest thing the advice I guess I would give for people is just, it's something new and change can be hard, but persevere. It is so flexible that if you find that the path you're going on isn't the best way to do it, experiment with it. There's that much flexibility within it that you can.
That's awesome. Melissa, what would you say?
I would agree that it's absolutely worth it. I think I would share with others two things. One, the application process, it can be very overwhelming. I know there are a lot of CCBHCs where their program director or whatever administrative staff is responsible for that, and doing that alone, I can't imagine what that looks like, because luckily for our agency, we have a whole team of administrators who are able to provide their expertise around different areas, whether that's, you know, the financial components or the grant itself, or our contracts department. So we definitely have a lot of supports. But on the other hand, the second point I wanted to share is that there is a lot of help and support available if you do decide to go this route and apply to become a CCBHC. Similarly to what Iris is putting on here, there are a lot of webinars that are available. There's opportunities through the National Council to learn about the different components and aspects of the CCBHC model of care, along with the requirements to sustain it and to apply for it. So I would definitely say, if you are looking to move forward in your application, seek out those supports because they are very valuable.
Thank you very much. That was really meaningful. Appreciate that. And Chandra, how about you? Was it worth it? And what would you want to offer to folks that are thinking about it?
Yeah, absolutely worth it. We are so very invested and passionate about this model. And one of the main reasons is just because of the overall outcomes for the clients that we serve. It makes the work very rewarding and meaningful. And the application process is daunting. We didn't necessarily have a specific team, but we did have a very much team approach to building the grant and then implementing the program. So I would certainly offer your organization a lot of grace. You do have to shift directions, think outside the box, but again, the grant allows for that type of flexibility. And yeah, just persevere, as was mentioned. That would be my advice. It's worth it in the end.
I really appreciate that, Chandra. The grace, the patience, the time that it takes, but as you've all three said, it's worth it. It's an extra level of scrutiny and tracking of data, but we all have to get better with that. You know, the NOM system, like many other measurement-based care and models, are necessary moving forward as we get into value-based care, population health, things that are going to make it more accessible, but also more affordable for people with better reimbursement modeling for behavioral health and substance use disorder services, because that needs to go up a little bit more. And I know CCBHCs get some additional funding, CSEMs, collaborative care management, some new codes there, but increasing the level of reimbursement for behavioral health services would go a long way to helping expand that. So the quality, the integrity, the tracking of the data is really important. It's a discipline. It's hard. Someone once asked me, he said, well, how do you know your patients are getting well at all your clinics if you don't measure it? I was like, because they say they are. They say thank you. They are getting well. They're feeling better. But we have to find ways to communicate that numerically, and that's sometimes challenging for many of us that are clinicians. So let me ask you something, because access to care is really important, and we're finding too rapid access to care, and crisis work, crisis coverage is important. I'm just throwing this out to you all to throw out a couple. How does your organization handle that in terms of rapid access to care, next day or same day or within a few day care service for somebody presenting? What are some models that where that's been helpful or not?
Well, we moved from scheduling a person who called and wanted services. We would then schedule an intake, and then we would schedule an assessment, and then we would schedule a treatment plan. And we just stopped that model altogether and adopted MTM's same day service, same day access. And so now whenever a person wants services, they just come in through the door. And they get the assessment the same day, and then it's just on to whoever their service provider is going to be. The challenge with that was making sure that we had enough people at the door available for them as they walk in. But it has definitely created a positive impact in terms of them being able to get their service quicker.
Yeah, so true. And, crises come up when they're there for the patient. It's not always, I have a crisis now, and a month from now I can go see somebody. Melissa, how about you? You were going to say something.
Yeah, I think I would speak more to the crises requirements. As a CCBHC, you are required to provide 24 hours, 7 day a week, 365 crisis support services. And so this is probably the question I get most in these kind of situations. How do we meet that? There are a lot of agencies that don't already provide that service. We do, and we have for as long as we have provided mental health services through our programs. It's actually a part of one of our contracts, and so we basically were able to expand that model. So we have like an on-call schedule, a rotation that happens with all of our staff. And so after hours, if it's the assigned staff is not available for the client who is in crisis, then it goes through an exchange kind of process, and they get in contact with the on-call clinician, who then also assesses the client, and then if hospitalization is needed, then there is another, what in LA County, it's a LPS designee, who can respond to that crisis situation regardless of daytime and all of those circumstances, to then get the client that support. And so that's a model we've been using for quite a while, but I think for most agencies who don't already provide that, that is probably the biggest turnoff to this model. Is I don't know how we're gonna implement this or meet that requirement. So I think too the rollout of the national 988 number has been really paramount to that process. Since there are local providers, connecting with those providers as a CCBHC meets that requirement. In addition to that, it provides the follow-up and maintenance care after those crises. So you can still provide CCBHC services through the model and meet that requirement if you don't currently provide the service.
Okay, so that's really helpful to hear. It is a struggle to provide that, but that's what we're striving for. All of us is just meeting patients where they are when they need service. And Sean, I'm going to ask this last question of you, and you give you 1 minute if we're getting close to the end. But how has virtual care been at your organization? I mean, we all had to learn how to do it during COVID, but in terms of CCBHC and connection of services, how would you rate the importance of seeing patients virtually and connecting to them, whether it's calling them or some other type of EMR connection or video platform? How has that been for you all?
Yeah, so our agency is probably we've had a mix of telehealth and in-person services for probably the better part of 10 years, working with IRIS providers. And just due to staffing shortages of psychiatrists and psych NPs, it's been really important for us to have that balance. But even beyond that, as we've been able to hire more psychiatrists these last few years, I don't know why, but it's been a good thing to have a balance of in-person and telehealth. Again, particularly in our rural areas, because oftentimes they just don't have the means to get to clinics. And we've noticed that our no-show rates improve when we have this option available. And I think, COVID certainly broadened that and allowed us to have access. Our regular providers also have access to telehealth billing codes, which has allowed our QMHPs as well to provide a lot of those services. So ultimately, our folks are getting service that is accessible to them and means that we can serve more people and do a better job.
Great. Well, thank you, Sue and Melissa and Sandra. Thank you for sharing your organization's journey and story with becoming a CCBHC and some of the challenges and successes. And it's heartening to know that your organizations would do this again, that it is worth it to reach out, to take the risks, to do the work. And this webinar, I think, is going to encourage others to do that directly. So thank you. I want to thank Ellison and her group for helping behind the scenes with tech issues and queuing things up for me. They're just lucky to have the staff here at IRIS to support what we do. And just everybody to keep an eye on LinkedIn and other socials where we're going to be offering more such things, and stay connected. So thank you, and thank you, audience members, for tuning in today. I hope you've enjoyed this time. I look forward to our next webinar. You all have a great rest of your week.